All right, it is 10:25. So welcome. My name is Danielle Lauder, and I'm the director of the Northeast Telehealth Resource Center. And I'm very pleased to be here with you today for our second Friday in our 4 Friday series for the virtual telehealth conference. Thank you very much for joining us here today. Just a couple of little housekeeping things. Please make sure that you use the Q&A in the EventMobi app to ask your questions, just so that we can keep track of them all. If you have a technical difficulty, it's okay to put that in there as well, and we can be sure to help you, because we've disabled the chat here in the Zoom room, just so that we can keep track of all the questions in the Q&A in the app. So please do that. We love and appreciate engaged audiences. So without further ado, I am going to introduce our speaker, and we're so very happy to have him here with us today. Dr. Dan Halpern-Reuter, or Dr. Dan, as we know him. We've had a wonderful opportunity to work with him over the past couple of years, is going to be presenting on eHealth tools of engagement, deconstructing the healthcare value proposition. Dr. Dan has a unique perspective. He spent many years working in emergency and urgent care, has perspectives in occupational medicine, healthcare management, entrepreneurialism, and quality management, but has a real passion for ensuring patient engagement and effective utilization of eHealth tools. And I'm just so very glad to bring him with us here today and to share his time and expertise. We thank him very much for doing that here with us today. So without further ado, as we mentioned earlier, we're going to keep these introductions very short, because we really want to give him the time to dig into this topic. And then for you to engage him, we'll leave about 10-15 minutes at the very end of the session to do an open Q&A. So without further ado, Dr. Dan, please take it away.
Well, thank you very much, and good morning, everybody. I want to thank you all for coming. I also want to thank Danielle, who we just heard from, Danielle Lauder of the Northeast Telehealth Resource Group, and Kathy Wibberly of the Mid-Atlantic Group for having me back this year. I want to thank both of you and your centers for pulling this together, and I want to thank everybody that's out there for coming. So while telemedicine has become a household word with the pandemic, we have to consider the trajectory of eHealth. That is the thing that is more than just telemedicine. The current embrace will become long-lasting only if we can clearly show value. So this is what drives the C-suite. Now, independent of what organization you're in, its size, there are people that are struggling with the finances, with keeping all of the providers well supplied, with keeping the thing going. And so they have a little bit of a different outlook on life, and we have to be sensitive to that. They want us to cut costs. They want us to improve outcomes. They want us to improve the return on investment of their EMR, which in many instances is unbelievable sums of money. And they want to stop they want to stop patient leakage. Now, patient leakage means that were we to develop a value-based contract with an insurer, we want to make sure that the patients that are in that cohort use our services exclusively. So we want to create a service presence which will do that. Obviously, you can't round them up all in a corral of some sort, so we need to provide goods and services to these patients that make them want to be with us. So just as a part of a background, very quickly, the SARS pandemic, I believe will redouble the push to value-based healthcare. And that's because increasingly we're going to need to control healthcare cost, and the value-based ecosystem is a really good way to do that. In that system, reimbursement is capitated, and therefore healthcare enterprises needing to maintain their resources and flourish in a value-based world will only do it by reducing cost and at the same time, or and at the same or hopefully improved quality. That's a big order, but medicine has been a big order for a long time, and I think we can do it. What's up ahead in this talk is first, we will consider the healthcare value proposition and propose 4 pillars of value, quality, culture, delivery, and the patient. I want to make sure that we all understand that the move towards value is multifocal. eHealth, I believe, is the horse galloping over the horizon just in time to help the enterprises of healthcare ratchet down cost while optimizing value. And I believe that eHealth can do it because many of the solutions at this point are off the shelf and are inexpensive. Thirdly, we're going to talk about optimizing the patient as the entity that generates the most effective ROI. And then we'll spend a little bit of time looking at the really enormous literature that is available to us to help us understand how we can optimize patient participation. So this is a slide that I think everybody's familiar with. It says that healthcare value is proportional to outcomes that patients want and to the cost of delivering these outcomes. I struggled with this literally for years, wondering how I can justify eHealth as a component of the move of the very arduous task of moving from healthcare that is procedure-based to an ecosystem which is now value-based. So my feeling was I have to justify the value of eHealth. How do I begin to do that? And I mean, how do we get to outcomes that matter to patients? How do we take cost apart to include direct and indirect costs? I struggled with this. And as a scientist, I came to believe that I had to take it apart. And that's what I did. So I deconstructed healthcare value. You'll have to excuse my dive into antiquity here. For centuries, people have struggled to understand how the world worked. As time went on, we as human beings continued to take nature apart and understand how it worked. Now we're at the subatomic level. We are struggling with how value works, being aware of the quintessence. That's the elusive 5th element. So I've, somewhat in a cavalier fashion, looked at water, fire, air, and earth, and analogize them to delivery, quality management, culture, and the patient. And to be aware that the nexus of these elements, these essences, is the quintessence, which is the 5th essence, which is that elusive element that makes it more than the sum of its parts. So that's what we're up against. And the way I broke it down was with this dizzying Venn diagram, which I tried to get everything in one place. It is dizzying, but there's also a beauty to it. So quality management, culture, the patient, and delivery, when optimized, produce value. So then our goal becomes to look at all of those elements and see how we can optimize them. So therefore, we optimize value. This is a little less dizzying a slide. I present it because that's what my slide designer wanted to do. But I still like my initial Venn diagram. So where we are is generating a new healthcare value proposition by deconstructing the initial one that I showed a few slides ago. The cost of healthcare will be optimized when each of the value pillars, quality management, multiple cultural realities, delivery, and involvement of the patient, are acted upon individually and synergistically, yielding high-value outcomes for the patient, the healthcare enterprise, and the society. So looking at those elements and what they mean, we have quality management, and I've just listed the elements of quality management that the World Health Organization has encapsulated. And these are safety, effectiveness, timeliness, efficiency, equability, and people-centric. Quality management is more than that. It's risk management. It's classic QA or quality improvement or outcomes management. But basically, all of those things want to make sure that we monitor these 6 elements. Culture, to be very fair, culture is more than one element, because we have the patient's culture, and we have the culture of caregivers, and the culture of the enterprise. I've included it as one because I think that in many ways the approach is the same, and I probably could be taken to task on that, and it's obviously open for discussion. Delivery of care, as we know, telemedicine has delivered care to millions of people that otherwise would not have had care in the current pandemic. And it's interesting that us in the eHealth world have been waving our flag for years, and all of a sudden we're exactly where the society needs us when they needed us. It's very gratifying. Finally, the patient, and I'm here to suggest that the patient as an entity is part of the value system, and that we need to structure the patient from passive to engaged to activated and co-producing. The next slide is and I'll warn you, this is a confusing slide, but this slide is my attempt to show how an institution would go about using the 4 pillars to evaluate innovations. So let's say a committee of 5 or 10 people is put together as the innovation management team. And they have decided, working with the CIO and the CMO and all those other folks, an algorithm to work from. And the algorithm I've chosen here, and once again, this is totally something that would be developed within an organization. And that algorithm for this presentation is that we are looking at each of these elements and grading them. Each member of the committee is grading these elements from -1 to 3 in my algorithm. Once again, this is open to innovation itself. And each member of the committee grades the innovation on its ability to promote and optimize each of the 4 elements. And this is a qualitative analysis, but in that multiple people are doing it, it develops some element of quantifiable. So the algorithm goes on to say that we will average over the group their score, and it goes on to say that any innovation which detracts from our ability to advance that pillar immediately disqualifies the innovation. Now that sounds pretty hard, but in my model here, what's happened is there was a negative one, at least one person in the group said, this innovation negatively affects our ability to promote the culture. And so therefore it fails, even though it has an 8.1 score. That failure is in this algorithm And an institution might say, we'll take one negative, but not more than that, or two negatives, but not more than that. And once again, that's totally within the enterprise to make that decision. So they go back to their desks and restructure X, and now the negativity is gone. It's got a score of +10, and so it passes, and the innovation committee says, here's something we need to do, and they get busy on it. So I hope, I suspect that's going to spawn a few questions, and I hope it does. So in the following slides, I ask the question, how does this eHealth application promote value? That is, how does this application of eHealth help optimize quality management, the patient delivery, and culture in healthcare? And once again, I just want to emphasize that the move to value-based ecosystem is galactic in size, and is not going to be solved by eHealth alone, but the eHealth is a highly economical and highly useful tool to help make that transition. So the first eHealth modality is telehealth, which I see as an educational modality. We change quality management because we help the patient articulate outcomes. We change the culture because we can inform caregivers how to deal with culture and how to understand it. And we also can give the patient and the patient care group resources to guide them through the barriers. Delivery, the most effective care is providing to the informed patient. In fact, the more informed, the less delivery. And finally, the patient, the eHealth modality of telehealth is educational and can help us move the patient from disengaged to engaged to activated. And by being activated, the patient comes to provide a significant percentage of their own care. And it turns out there's an enormous literature about all of this, and I'll cover some of this toward the end. And there are elements such as coached patient autonomy, activated patient, co-production, shared medical decision-making, and coaching. And we'll talk about how these, how I strongly feel these should be brought into healthcare environments so that we can move the patient along. Telemedicine, I think I don't need to go too much in this. This is something we all live and breathe. I will say that, and I'm going to talk about this when I talk about AI and augmented intelligence and natural language processing, that telemedicine, because it is a recorded event, or can be most easily a recorded event, will lend itself to the research that needs to be done so that we can evolve to automated encounter evaluation of 100% of the billion healthcare interviews that happen yearly in this country. From a cultural point of view, we're changing the platform of delivery to suit the patient. We all know that even when we go to see our healthcare provider, there's some element of intimidation of the office. And what we're doing is we're replacing it by familiar turf, restructuring the provider-patient encounter. Delivery is where telemedicine is a star, and there are elements of it, and we all know. But the element of delivery that I want to emphasize is the patient portal. I believe it is one of the least utilized but most valuable elements of eHealth. It should be a robust portal where patients will have internet learning, structured internet learning, They will have structured self-diagnostic, symptom diagnostic tools, and can come back at us with what they think is going on, which I think is just where we want to be. Currently, it's mostly used for labs, notes to and from patients, and appointments. And that's the least of what it's useful for. And other elements include the curated internet resources, so that when people do go to the internet, they look at the things that have an imprint to it. And finally, the patient, by doing telemedicine, has control over the site and circumstances of care. That's empowering. Augmented intelligence and natural language processing, many will say this is not eHealth. I'm here to say that it very much is. I believe that using AI and natural language processing, we can develop an automated chart review tool with 100% of chart review, so that we can monitor every encounter for its progress to preset metrics and outcomes. If that sounds futuristic, I will tell you that there are elements that are available now that in the business world, this kind of activity is very sought after, and it turns out to be the same technology that would allow us to do this in healthcare. From a delivery point of view, we can provide an encounter note in both the clinician's and the patient's voice for review at the end of each encounter. This takes away the burden of documentation, and it also, by the way, removes that keyboard between the patient and the provider, and will produce an encounter that is far more fruitful. And I want to say that currently when we do a patient encounter, the patient's voice is mirrored in a subjective evaluation that has been interpreted by the provider. So it's biased. So we really don't have the patient's voice in our notes, and we have the opportunity to do that. Once again, this stuff may sound futuristic. I believe it's really not that far off. And to the extent that we can feed AI research with our encounters, they can come up with solutions to this, which will be, which is a game changer in healthcare. And finally, there's remote patient monitoring, EMR, the PMR, digital health, mobile health. I think that the divide between remote patient monitoring and digital health is going away, that some of the apps are enormously powerful, and they can feed data into the EMR, making it more valuable. There is an opportunity to create remote patient monitoring of multiple channels. So say that we have a remote patient monitoring capacity to look at 6 physiologic parameters of a patient in an intense area, such as a nursing home. And we can develop algorithms that look at perturbations from the normal that is developed as a diagnostic tool of what's up ahead. For instance, the patient that feels a little sick because somebody with flu was in their room unbeknownst to everybody, or somebody with COVID was in their room unbeknownst to everybody. And we all know that we get a little sick. That's Judd Hollander's term, little sick, which I love. We all know when we're a little sick, and that's not a psychological issue, that's a physiologic issue. And if that turns up in physiologic monitoring, then it will, with the proper algorithms, it will become diagnostic. This is a little bit more futuristic, but there are elements of it already available. There's Jacqueline Picard's work at MIT, who has now, using only one physiologic parameter, the ability to predict a seizure within somewhere between 30 and 45 seconds of its occurrence, which doesn't sound like a lot of time, but it's time for the patient to advise people that he's or she's about to have a seizure and prepare for it. Digital health is a huge leveler of patient cultural issues because patients get to choose what apps they interface with. By some counts, there are over 300,000 of these out there. So we better learn how to use them because our patients want us to know how to use them and how to advise which ones are useful and which ones are perhaps less useful. And that of course goes back to the patient portal where we list as a healthcare enterprise, we list the 100 apps that we think are the most productive. And all members of the staff know how those 100 apps work. That's just part of their homework. So remote patient monitoring is not at maturity, but it will become there. My partner, Frank, Frank Melitz has developed the term tele-everything, and he's very right. If you go onto PubMed and just put in the MESH term tele, you get thousands of different tele-thises and tele-that's. Rehab, mental health, ophthalmology, dentistry, radiology, mentoring, orthodontics. Who would have thought? And in fact, in France, if you have a certificate in eHealth, you're actually paid a little more. And so there's an interesting twist. And this list goes on and on. So each telehealth this and that needs to see how it generates value. And that's a key piece. How does our application of eHealth produce value is the question that everybody needs to ask. So the radiologist, the dentist, the ophthalmologist, how does this produce value? That is, how does it optimize quality management, the patient culture, and delivery? So the pillars, as if you recall my Venn diagram, every circle touches every other circle. So that's, by its very nature, becomes synergistic because you can't manipulate one without manipulating all of them. I am going to propose that the patient as a pillar will bring the most immediate and enduring ROI. I hate to convert that into business, but we have to be aware that everything we do has to make sense, has to generate value. So this is a major rethink. We're talking about the patient as a resource. The patient must evolve patient care must evolve into a two-way street, which is synergistic. The enterprise in healthcare has responsibilities, and so does the patient. And I don't mean that to be mean-spirited. And I will show you that there are data out there that clearly demonstrate that the activated patient is much less expensive to take care of and has better outcomes. What could you want that's better than that? In a value-based world, the enterprise and the patient will benefit from the participating patient. The patient is a pillar of value, as is delivery, quality management, and culture. And finally, eHealth may be the single most potent tool in moving the patient from passive to engaged to activated. So you might say, well, wow, that's a pretty tall order. How do we begin to the patient in that direction? And I'm going to show you that, in fact, we know more about ways to increase patient participation than certainly I was aware of when I started down this road. I've chosen 4 to look at in in some minor detail, and that is the patient activation work of Judith Hibbert, a researcher out in Oregon, the co-production work of Paul Batalden, who's a researcher at Dartmouth. Shared decision-making has been around a long time. I think people are familiar with the term. I'm not certain how often it is actually a part of the clinical activity. And finally, health coach, which has also been around for a long time. Now, you notice that my little drawings are all sports-like, and so I continue this down on the fifth bar to say that there are others. It's not just golf, soccer, tennis, and baseball. It's riding bicycles and doing over land skiing and lifting weights. One size does not fit all. And it may be that any institution takes 2, 3, 4 of these, or decides that at first we're going to perfect health coach, and then we're going to perfect shared medical decision making, and that's the way we're going to go through this. So I'm going to just look very quickly at a few of these researchers. The first is patient activation, which Judith Hibbert out in Oregon has worked on for years, for probably close to 20 years, and has been able to demonstrate that patient activation does matter, and that patient activation is strongly related to a broad range of health-related outcomes. And that was back in 2012. Later on, she did very sound work and was able to show that when patient activation levels change, healthcare and costs change too, healthcare outcomes and costs change too, and in the directions that we'd like them to change. So that's now 5 years ago. And there is a very nice study where this was applied to high-cost patients and showed that changes in her patient activation measure demonstrated improvements in the patient's care. And finally, she came to the conclusion that one of the great impediments to her patient activation process was that providers really did not know how to get involved with that. And so for the last 3 years, there have been a few publications from her which look at that. I wanted to show her patient activation measure, and that is this slide where she has a measuring system where she can document that patients move from disengaged and overwhelmed to becoming aware but struggling, to taking action and gaining control, and finally to maintaining behaviors and pushing further. I'm my own healthcare advocate. I will tell you that there are many providers out there that fear that statement. I will tell you that it is the statement that produces the best outcomes, and it is the statement that produces the lowest cost. And so we need to be focused on that. That's our business, is creating good outcomes. And if this is a way to do it, we should embrace it. So other players in this field are Paul Batalden, who popularized co-production. Co-production is what we do when we check our food items out in the supermarket at the automated counter. It's what we participate in when we pay our bills online. That saves both the vendor and the customer time. So co-production is when we pump our own gas. I mean, I'm old enough to remember the time when that was not something that was common. So he's evaluated this whole world of co-production, and it's much like Dr. Hibbard's evaluation. And in fact, interestingly, he comes within the last year to the same conclusion. And I think this is a very powerful statement. The authors argue that health profession learners cannot be educated in a traditional paternalistic model of education and then be expected to practice in a manner that prioritizes co-productive partnerships with colleagues, patients, and families. I think that is a very powerful statement, and it's one we need to pay attention to. It's a how do we get there statement, and what do we need to get there. And finally, there are two more left. One is shared medical decision making. This is the first is a 1999, so 21 years ago, saying that considerable evidence that patients want to be consulted about the impact of treatment. Shared medical decision is an important development in healthcare. That's 21 years ago. Instruments for evaluating shared, there's a whole compendium. You don't have to reinvent the wheel. It's all out there. And in fact, the Association of American Medical Colleges has a toolkit for it, which is available right online for free. And finally, there's the health coach. And the health coach is a concept that's been around for a long time as well. This and the health coach may simply be telehealth, which is, it may be there is an MA that after a patient examination steps out and says, I want to introduce you to our patient portal. I want you to know how to use it. And I want you to know that if you have any problems in using it, I'm there for you, or if you have any further questions. And so we have this electronic health coach now, which is quite valuable. And I've provided, there's a compendium of that as well, and I've provided some basic research, which I think deserves attention, about how health coaching can change the way, the efficiency with which we do things. So that's a view of where I see the healthcare imperative to value and what we need to get there. I took this picture at 30,000 feet. It is a landscape. This was, by the way, a color picture, which turned out to be totally black and white and gray, and all the scales in between. And I thought that it was gorgeous. A river is running through farmland, and the light snowfall has changed gradients of the color. I think at first it's like, wow, that's an interesting abstract painting, but in fact it is a photograph untouched. And it is the view at 1,000 feet. I see that this light snowfall on farmland is beauty and complexity, and that is what we're talking about. So what I've done is I've deconstructed healthcare value to 4 pillars and suggested that that provides the opportunity to innovate strategically. Secondly, that eHealth offers opportunities to cost-effectively address elements of the value pillars, and also that eHealth is not the only tool that we need. Activating the patient may be the most cost-effective innovation on the table. That there is a robust literature looking at patient participation, and I presented the literature in a sort of bulleted form. It is out there. Most of it is free, and it is easily done, but we need to look inside the culture of the institution and culture of the establishment of the medical enterprise, and see what cultural stops are there that would frustrate this. And we also need to look at the patient to understand their cultural liabilities and understand what we can do to help them obtain quality health care, thinking about those challenges. And finally, eHealth has the tools to cut. I hope that I have convinced people that eHealth has, I don't think any of you need convincing personally, but that eHealth has the tools to cut cost, improve outcomes, improve the ROI on the enterprise's EMR, and stop patient leakage. And as I said, in a value-based world, we can't thrive in a value-based world with patients that seek care in places other than the one contracted to provide their care through a value arrangement. So I finished a few minutes early. I would love questions if they're out there.
Excellent. That gives us just a little bit of extra time to dive into some questions. And Jason is actually going to, actually, we don't have any questions in the Q&A at this very moment. You can feel free to go ahead and type those into the Q&A if you'd like. But even better, if you want to raise your hand or chat that you would like to ask a question, I'll go ahead and unmute your microphone and you can ask it out loud. We'd actually prefer that. I think make this a little more interactive. But thank you so much, Dr. Dan. I mean, gosh, he gets you thinking, right? I mean, it's just such an important topic, and patient engagement and looking at, you know, across the different pillars and considering those all when you're planning a new initiative. It's very thoughtful.
So I've got 2 raised hands out there. One's my buddy Frank.
All right, so let's go ahead, and Frank, you are now unmuted.
Come in, Frank.
Can you hear me, Dan?
Absolutely.
Can you hear me now?
Can you hear me now? Yes, Frank, I can.
The talk gets better every time you give it, so thank you, sir.
Oh, well, thank you.
So the question is around language. You spend a lot of time, and correctly so in my mind too, focusing on patients' accountability and responsibility as part of the co-produced system of healthcare. We've spoken for so long in the current system of entitlements and patient rights and the passive delivery of healthcare that they just sort of absorb. What language do you think is critical, mission critical, to getting patients to be more accountable and to realize that they are so integral to the value proposition of true healthcare delivery?
Well, that's a really good question. I have to say, you clearly don't say, look, I'm going to educate you so you're cheaper to care for. That would be a non-starter. I think that you start sequentially, and maybe you start with coaching every patient or a cohort of patients. Maybe you start educating patients about the patient activation measure and how they can fit into it. I think you present it as an opportunity to have better outcomes. And I think that with the patient, you focus on that. And to be frank with you, as providers, we need to be focusing on that. The C-suite guys may be looking at slightly different issues, but they know that if we engage the patient and create an activated patient, they're going to have an easier time maintaining the resources they need to run the organization. So I would do it as a successive approximations where you do a little bit and people say, hey, this is sort of neat. And you do a little bit more and they say, this is really neat. And they do a little bit more and they say, doctor, I've had this symptom for a while and I think I have blank. And you say, oh, how'd you get that? And they say, well, I went to the portal and I got your curated list of internet sites and I did a little bit of learning there, and this is what I think I have. Now, many providers currently would look at that with dismay, saying, oh, you're looking at Dr. Google. And I would propose to you, they say, wow, that's really interesting. You did a great job. Let me tell you what I think of that. And so now you have a very productive discussion where the provider and the patient are much more on the same ground. None of that paternalistic stuff. Does that answer the question?
As usual, perfectly.
Okay.
Of course.
And I like the answer.
This guy's the best partner anybody could ever have.
Is he a plant?
Yeah, I think so.
Rocky Kelly, you are unmuted to ask a question or make a comment.
Yeah, so I have a question. One group that's been shown by the research to have sort of systematically lower patient activation is older people with hearing loss who tend to delay getting care and have more worse health outcomes, more complications in the hospital, and generally lower patient-provider communication satisfaction rates. I should introduce myself. I'm Rocky Kelly. I'm an audiologist as well as a researcher. I am very interested in the opportunity that telehealth presents to, because we've already got this technical component as part of patients' visits, it provides an opportunity for us to actually control the audibility and amplification of the provider communication to the patient. And so I haven't seen anybody talking about that or working on that. In fact, of all the standards that exist for telehealth, audibility is one of the areas where there really isn't, there are no standards. The compression algorithms that different programs use aren't documented in easy to find ways. My question is whether or not you are personally aware of any research in this area, and if you were in my shoes, where might you look for support or interest for this kind of area of questioning, specifically to see if we can provide tools for patients with hearing loss through telehealth that would allow them to increase their patient activation in ways that aren't possible in face-to-face visits.
Well, thank you. One thing that occurs to me immediately is looking at digital health or mobile health. These are the applications that people can import into their phones, which are hardly phones anymore. A huge percentage of the population has them. And as you know, these devices can be fitted out to pipe right into hearing aids and other devices. And it might be that there's a lot of fertile ground out there I don't know of any one, but as I noted in my show, some people think there are as many as 300,000 of these things. So finding the right one, and by the way, the AMA has a subcommittee on looking at the effectiveness of some of these. So that would be a great place to start. And if you go to the AMA and digital health, that organization will come up, and they have at this point hundreds that they've graded as to their user ability and health usefulness in healthcare. That's probably where I would start. You also obviously can go to PubMed and search telemedicine and audiology as a Boolean search, and almost certainly come up with resources there as well.
Great. Frank, I'm wondering if you might have something to add to that. You put your hand up pretty quickly after Rocky asked her question.
Thanks, Danielle, for watching my hand. I think Rocky's question is very conducive to Dr. Dan's presentation, because here we're talking about a cohort of patients, the hearing impaired, the deaf patient population, and we're kind of co-designing and co-creating this as we move forward. A website that may be integral to this process is Patients Like Me. I have been a member of that for a bit now. I have a condition in my hands called Dupuytren's contracture, and I'm now in touch with 250 patients across the globe who also have had experiences with hand surgery and failures just like me. So if we're trying to activate patients and get them to be more involved in their care, patients with hearing impairment might go to Patients Like Me as a curated site, begin to interact, maybe co-produce is the right word, relationships, and as they develop their own best practices, all boats will rise. And I think that's something that someone like Rocky, who's a researcher, can purport to a few of her patients, get them involved, and all of a sudden we're going to start to find in the telehealth community more resources that the patients develop with us.
Mm-hmm.
Thank you.
You bet. Yeah, I was actually, in trying to start a conversation, I was the one who put in the plug for Nothing About Me Without Me in the Q&A. And I think that wholeheartedly think that applies to this situation. Really patient engagement and development of tools. And don't forget to, about the policy end of things, working to change policy around some of the tools that are available and how they're developed, and et cetera. So Priscilla has a question. With the sheer volume of options for eHealth, how do we prevent overwhelming patients? Big question.
Well, I mean, that's a great question. And my answer is you just can't do, you just have to look, you know, the nice thing about telemedicine is that you can see the patient's face. And when you see the patient's face, there's volumes there. If as a physician, as a healthcare provider, I knew when I was up against trouble. I could read it in the patient's face. I knew when they hadn't understood what I said. I could see it in the patient's face. And so, as healthcare providers, we can lead patients down the trail and watch their faces sort of clearly, and not just their faces, but what they say and what they eventually do, and understand quickly that they are overwhelmed or that they're hungry for more. So I think that's why we still have healthcare providers and not computers taking care of patients, because we need that sensitivity to understand how much, how far, how fast. Does that answer the question?
Mm-hmm. Yes, yes. So Ed has a question. Activating the patient is so appropriate. How do you see the role of patient incentives, and that specifically financial incentives, cost avoidance on the part of the patient when so much is paid for the system, i.e. Medicare and Medicaid?
I'm really not an advocate for that. I think that if the only thing you can do is appeal to their pocketbook, I think you failed as a provider. That you know, getting $2.43 for getting to a hemoglobin A1C of 6 or something like that is I think wrong-spirited. I think that's wrong-spirited. I know there are people out there that would disagree with me, but personally, I don't think that economic incentivization is the way things should go.
All right, we have another question from Margie. With such a low percentage of patients using portals, what do you think of patients using telehealth home monitoring systems to improve the physical exam, systems like TytoCare, for example, Will patients end up using this, and how far down the road do you see coverage of these types of things for patients at home?
Well, I think that that telemedicine is so the self-monitoring thing is only going to increase exponentially, and I think that it becomes. I mean, I see every healthcare encounter ending up with the patient being walked to a resource room where the MA or some like similar person goes through the portal, talks about the resources, shows them what's there, and becomes their portal person at the practice. And that the power of that is that by telling one, you tell all. So that's hugely cost effective, and I think is just the way to go. Low patient portal utilization is known, and I would tell you, just as a portal user myself, it's barren. First of all, they're confusing. They're not engineered well, and they don't. I will say that years ago I took an ACLS course virtually and couldn't pass it. And I'm a board certified in emergency medicine, and I'm like, I can't pass this. And then I realized that the computer jocks had, the nerds had designed this program. And in fact, the oxygen line that I needed was in the kick bucket at the base of the patient's bed. So I said, okay, now I understand this is a game. So just like in games, you look under the rock for the key to the kingdom. And so I passed it the next time I took it. So we need to have these sites developed with patient input and with provider input so that they're easy to use, and we don't do, I discourage doing workarounds from this when it's already there. You've already, the healthcare enterprise has already paid for it. And it's sitting there as a resource, which I think everybody agrees is underutilized. And I believe that it's our duty to make this friendly, useful, and it will change the patient. I strongly believe that.
Frank, do you have a really quick comment? And then I'm going to unmute Rishub, who has a question.
No, go ahead for the question. It's time for the questions.
Okay, so I see, Rishub, that you actually chatted in the chat, but if you would like, I've unmuted you if you'd like to ask your question.
Yeah, of course. Thank you so much. So just for context, I frequently work, actually, I'll roll back a little more. I'm a college student working on developing a telehealth platform for opiate addiction recovery, specifically medication-assisted treatment, where prescribers give these medications to help quell withdrawal symptoms so they can focus on counseling and other aspects of recovery. But one thing I frequently find is that it's really difficult to activate the patient to get them to be an active proponent of their own recovery because there's this massive lack of trust with the provider. So how do you suggest kind of either building that trust or just how do you suggest getting over that barrier to activate the patient?
So are you pre-med or pre what?
I'm biomedical engineering.
Biomedical engineering. Well, so I've done medicine. I'm 73. I've done medicine for a long time. And if the patient cannot be activated, it is, and I know that somebody's going to be waiting for me with a gun, but I will say that it is the provider's fault. That if you can't read the face of the patient and understand where they are and what their needs are, and then provide the environment. Now, addiction and recovery stuff is frightfully difficult, and I actually invite you to talk to my partner Frank, who for whom that is a very strong element in his professional career. He's an orthopedic surgeon, but he has a huge interest in addiction and addiction recovery, and he may be a very good person for you to chat with about this.
Yeah, thank you so much for the connection. I'd love
Yep.
to get in contact with Frank.
Okay, good.
And Frank, feel free to jump in real quick. And then, guys, we're down to 1 minute left, so we'll have to wrap it up. Apologies for anybody if we didn't get to your question. But this is perfect. Leave them wanting more, right? And please do reach out to us. We can connect you with Dr. Dan or with Frank, but feel free to comment.
Yeah, and just before Frank says, the talk is online within the website. My email address is drdanhr@gmail.com, and I'm not sure that that's there. But write to me. I will answer your questions. If you'd like, we can actually do a little Zoom meeting so we can see each other's faces. And I would be more than flattered to participate in any of that. Take it away, Frank, for 30 seconds.
So Rashub, thank you very much for that comment. My passion over the last 3 years has been neuroplasticity and the addictability of the human brain. The quick comment I have, since we don't have much time, is that your work is going to give you a lifetime of sheer pleasure because you're going to have lots to do. Just remember that folks that are in the throes of addiction have cognitive cerebral cortical hijacking. So a lot of the critical things like decision making and cerebration and some of the things that we're talking about here that require significant cognitive abilities are at least temporarily hijacked. So you may have a little trouble with getting through to them. Please don't get frustrated by that. And my email is fmalitz, M-A-L-E-T-Z 7252 @gmail. And we should talk some more offline.
Awesome. This is perfect, guys. Thank you so much to Dr. Dan, to Dr. Malitz, to all of you for attending and being so engaged and having wonderful questions. Just as 2 reminders, guys, because we are out of time, please go into this session and complete the evaluation or the session feedback. We really love to get your feedback on what we can do to improve next time and what you liked, because we want to continue to do that. And also just a reminder, please join Dawn for the stretch break, the virtual stretch break. She did an awesome job last week. So if you have time, and get up out of that chair and stretch. But thank you both so much again, Dr. Dan, and to Frank as well, for all your expertise.
I've put up the evaluation slide. I just want to make a real plea. This work is very important to me, and it's critical that I have done a good job. I am looking for people that say you didn't do a good job here or you didn't do a good job there. That is hugely valuable to me. Do not be shy. I need all the help I can get.
Thank you so much to everyone. And thanks again, Dr. Dan and Dr. Malitz.
Bye.
Have a great
Bye
day.
now.
Bye.